The ambulance doors opened before the rain finished sliding off the bay lights. 2:06 a.m. Storm wind pressed against the glass panels of Walter Ridge Medical Center's trauma entrance, bending the trees in the lot. The fluorescent lights inside hummed louder than usual, or maybe it only felt that way because every stretcher wheel seemed amplified tonight. 2 security vehicles idled behind the ambulance. No sirens, no flashing spectacle, just presence. The paramedics moved fast but controlled, the way professionals do when panic would only slow them down. "Male, early 20s, one called out. "High-speed collision, extraction complicated, suspected cervical spine involvement, hypotensive on scene." They did not say his name, they did not need to. The boots near the stretcher were polished. The plainclothes security detail kept distance, but never relaxed their shoulders. One man held a phone at chest height, not recording, reporting. The air shifted. Someone at the nurse's station whispered, "That's the general's son." The words traveled without sound. Pressure filled the trauma bay like an invisible gas. Lena Ward stood near the supply cart, already gloved, already steady. She had been floating between ER and Neuro ICU for 2 weeks, still new enough to be corrected for speaking out of turn. The stretcher locked into place. The patient's face was pale beneath streaks of rain and dried blood. A cervical collar held his neck rigid. His chest rose shallowly. Monitors were connected in practice sequence. Dr. Kessler entered last, senior neurosurgeon, reputation heavy, voice heavier. "Clear the room," he said sharply. "Primary survey." The residents shifted into formation around him. Lena stepped back automatically. "Ward," the charge nurse murmured beside her, "your secondary support. Monitor and chart. Do not initiate." "Yes," Lena replied quietly. Kessler's gloved hands moved with confidence. "Mechanism? Vehicle rollover. Extraction required roof removal. Loss of consciousness? Brief. Movement at scene? Unclear." Kessler did not look up. "Pupils equal," a resident reported. "Breath sounds diminished, but present. Blood pressure dropping." Lena's eyes stayed on the details others skimmed past. The abrasions along the shoulders, the angle of bruising across the clavicle, the rigidity in the upper thoracic region that did not match a pure axial compression. She listened to the paramedics' earlier phrasing. Extraction complicated. That meant movement, possible lateral force. She stepped closer to adjust the blood pressure cuff. Her hands were steady. The monitor displayed fluctuating systolic numbers, low but not catastrophic. Kessler turned toward imaging. "Get him to CT immediately." "We're still stabilizing," a resident said. "He needs imaging now." The word now cut through the room. Lena glanced at the alignment of the cervical collar. Too tight on one side. She corrected it subtly, millimeters only, without announcing the adjustment. Her gaze moved to the patient's rib expansion. There was a hesitation in the left intercostal space. Not paralysis. Guarding. Subtle. She checked the field immobilization note attached to the clipboard. Improvised stabilization during extraction. Her jaw tightened slightly. Improvised meant hands under pressure, hands that may not have maintained neutral alignment. She had seen that before. Compression injuries present differently from shear. Compression drives straight down. Shear twists. The bruising pattern suggested torque, not full transection, not clean. But the room had already chosen its direction. CT results returned quickly. Kessler scanned the images on the overhead monitor. "C6 involvement," he said. "Severe cord signal change." The resident stiffened. Silence gathered. "Complete?" one asked. Kessler exhaled once. "Highly likely." The words settled into the room like a verdict. "Spinal cord injury," he continued. "Prepare family consultation." Likely permanent. The phrase was not spoken loudly. It did not need to be. Lena's eyes did not leave the patient. His diaphragm movement was irregular but not absent. There was tension in his jaw, not random, controlled. She adjusted the pulse oximeter and noted the waveform quality. Strong enough. Perfusion present. Spinal shock window had barely begun. It was too early, too soon to declare finality, but hierarchy in this hospital ran deeper than doubt. The security detail shifted when the words reached them. One stepped out of the bay. Phone lifted again, reporting upward. Within minutes, footsteps approached from the corridor, measured, heavy. The general did not enter immediately. He stopped at the threshold, tall, controlled, expression unreadable. He listened to Kessler's summary without interruption. Severe cervical injury. We are preparing for likely permanent neurological deficit. The general did not react outwardly. His hands remained clasped behind his back. His son lay motionless under the lights. Lena stood at the edge of the bed, hands resting lightly on the monitor stand. She said nothing, not because she agreed, because timing mattered. She reviewed the perfusion readings in her mind, reviewed the mechanism, reviewed the bruising, reviewed the sedation timeline, reviewed the shock window. Permanent was a word used too early under bright lights. She recorded objective data in the chart. Respiratory irregularity noted. Perfusion marginal but responsive. Sedation minimal. No public challenge. Not yet. Kessler turned to the team. Prepare neuro-ICU transfer. Begin paralysis protocol education for family. The room moved. Orders followed rank. The storm outside intensified, rain hammering against the glass like distant artillery. Lena adjusted the IV line again, checked the alignment of the spine, felt the faint resistance in the lower limb muscle when she repositioned the sheet. There was something there, small, buried, but present. She kept her head down and watched. The word permanent entered the room before the swelling had time to settle. It came wrapped in clinical certainty. Based on current imaging and presentation, Dr. Kessler said, voice level but firm, we are dealing with a severe cervical spinal cord injury. Functional recovery is unlikely. Unlikely. The residents heard final, the nurses heard final, the security detail heard final. The general stood at the foot of the bed, posture straight, hands still clasped behind his back. His face did not move. Years of command had trained his expression into discipline. Only his eyes shifted to his son's chest rising beneath the trauma blanket. Slow, uneven, but rising. The room reorganized itself around the declaration. A consult note was opened. A surgical plan began forming in low, urgent tones. Words like decompression and stabilization moved through the air. No one mentioned spinal shock. Not yet. Lena stood near the monitor, chart tablet in hand, her badge catching the fluorescent glare. She kept her shoulders small, posture neutral. She listened, she watched, she counted breaths. The ventilatory rhythm was not purely mechanical. There was a pause at the end of each inhalation, a fraction of hesitation, subtle engagement of accessory muscles. Complete transection injuries often altered breathing differently at this level. This pattern was inconsistent. Her gaze dropped to the sedation record on the screen. Initial field sedation, minimal. Emergency department sedation, light dose administered 28 minutes prior. Paralytic agents, none currently active. She traced the timeline in her mind. Extraction, transport, imaging, declaration. The neuroshock window had barely opened. Spinal shock can mask function temporarily. Reflexes disappear. Tone vanishes. The body looks empty. It is not always empty. She adjusted the pulse oximeter sensor slightly. The waveform stabilized. She leaned closer to reposition the blanket. Her fingers brushed the patient's forearm. There it was again. Not movement, not reflex. Tension, deep, like a body bracing quietly. Kessler turned toward the general. We will proceed with surgical stabilization to prevent further damage, but you should prepare for permanent loss of motor function below the level of injury. The general absorbed the words. Understood, he said. Nothing more. No visible collapse. But his jaw tightened once. Lena's eyes flicked to the ventilator screen again. End tidal CO2 stable. Heart rate responsive to minor environmental changes. She shifted slightly to view the patient's lower extremities beneath the sheet. No gross movement, no obvious response, but the toes were not fully flaccid, not entirely. She bent slightly as if checking the IV site. Her hand brushed the lateral aspect of the foot. Light contact, no overt stimulus. There was the faintest change in muscle tone. Not a jerk, not enough for the room to notice, enough for her. She straightened. Kessler continued outlining surgical timing. Residents nodded. Notes were typed. The machine of hierarchy moved forward. Lena opened the sedation chart again. 28 minutes was too short to declare final neurological absence under these circumstances. She calculated silently. If this were a complete transection, certain patterns would present clearly. The CT showed severe signal change, yes, but edema can mimic severity early. Imaging captures structure. It does not always capture function. She stepped back as a resident adjusted the cervical collar. The patient's breathing pattern shifted slightly when the resident leaned over his face. Heart rate increased by 4 beats per minute. Not dramatic, but responsive. Complete paralysis does not erase autonomic response entirely, but this was deliberate, measured. Lena swallowed the impulse to speak. Public correction would harden the room against her. She was new, float nurse, probationary. Dr. Kessler had built his career on decisive calls. To challenge him now, in front of the general, would close doors she might need open. Instead, she documented. Respiratory variability noted. Sedation timeline within early window. Minimal muscle tension present in lower extremities. Objective language. No accusations. The general stepped closer to the bedside. He rested one hand on the rail, not touching his son, just near. "Is there any possibility," he asked evenly, "that assessment is premature?" Kessler did not hesitate. "The imaging is clear." Imaging. Lena's eyes lowered. Clear does not mean complete. She adjusted the blood pressure cuff again, ensuring accurate reading. Systolic slightly improved. Perfusion matters. Spinal cord perfusion pressure determines outcome in the early hours. She could see the path forward forming in her mind. Not confrontation, observation, time. There was still time. The general nodded once. "Proceed," he said. The word landed heavy. Lena stepped back into her assigned perimeter. Monitor, chart, observe. The storm outside intensified again, thunder rolling faintly across the city. Inside, the verdict had been spoken, declared, but not yet proven. She kept her head down and waited for the window no one else was watching. The trauma bay emptied into a quieter rhythm as the surgical team prepared upstairs. CT images were still glowing on the monitor. C6 signal change. Edema spreading like smoke through grayscale tissue. But Lena did not look at the images again. She looked at the paperwork. The initial field report lay clipped beneath the electronic tablet, partially scanned into the system. She lifted it gently, as if it might tear under the weight of oversight. Extraction required roof removal. Patient repositioned during secondary stabilization. Collar applied post-extraction. Post-extraction. Her jaw tightened slightly. Neutral spinal alignment should be maintained before movement, not after. Under fire, in combat zones, they sometimes improvised. She had seen Rangers carried across uneven ground because the alternative was worse. Improper immobilization does not always sever a cord. Sometimes it shocks it, temporarily. She traced the sequence in her mind. High-speed rollover, lateral force, possible torsion, extraction without full immobilization, secondary collar applied once clear. A shear injury could look devastating on early imaging. It could also recover partially if perfusion was restored quickly. She closed her eyes for half a second. Memory intruded. A dusty road, a ranger pinned beneath twisted metal, no movement below the waist, silence in his eyes. They had thought it was complete. It wasn't. She opened her eyes. Different setting, different night, same pattern. The patient's chest rose again beneath the sheet, still irregular, still guarded. A resident stepped closer to adjust the IV line. "Transfer to Neuro ICU in 5, he said, mostly to himself. Lena nodded, as if agreeing. She moved to the side of the bed and positioned herself where she could access the patient's hand without drawing attention. Non-invasive, minimal, no dramatic stimulus. She placed 2 fingers lightly along the lateral edge of his forearm, brushing the skin as though smoothing a crease in the blanket. Nothing obvious. She shifted to the foot. Her thumb pressed gently against the plantar surface. Not a painful stimulus, just contact. There it was. Not a jerk, not a reflexive withdrawal, a faint tightening, like a muscle remembering its job, so small it could be dismissed. She repeated it once, slightly adjusting angle and pressure. Again, a fractional increase in tone, barely perceptible. The resident noticed her hand movement. "What are you doing?" he asked. "Checking alignment," she replied calmly. He glanced at the monitor. "Reflex artifact," he said dismissively. "Spinal shock can cause random activity." She did not argue. Random is not patterned. This was patterned. The timing was consistent. She moved to the sedation chart again. Initial dose, low. No paralytic agents administered since arrival. Sedation window, light. Time since dose, now 36 minutes, insufficient to mask all motor response under these conditions. She checked the medication administration log again, line by line. No hidden bolus, no accidental double dose. Vitals stable enough to preserve spinal perfusion. She stepped back as the resident adjusted the cervical collar once more. The patient's jaw tightened subtly at the repositioning. Not reflex, reaction. Complete injuries don't guard, she thought. She kept her face neutral. The resident began preparing transfer paperwork. "Neuro assessment already done," he muttered. "No response to pain, no motor function." Lena looked at the clock. The full neurological assessment window had not elapsed. Spinal shock can suppress reflexes for hours, sometimes days, but declaring permanence at under an hour was premature. She moved again to the bedside. This time she observed breathing under closer scrutiny. There was slight asymmetry in diaphragmatic engagement. Subtle, but present. If the cord were fully transected at this level, certain respiratory compromises would be more pronounced. This pattern suggested incomplete involvement. She checked the lower limb temperature gradient, perfusion improving slightly. Her mind calculated quickly. If perfusion pressure increased marginally, micromotor return could strengthen, but intervention required timing and authority. She adjusted the sheet once more, letting her fingers brush across the patient's toes. There, clearer this time, a faint twitch in the second toe. She kept her expression unchanged. The resident noticed again. "You're chasing ghosts," he said quietly. "Documented," she replied softly. He sighed. "Imaging doesn't lie." She looked at the CT screen. Imaging captures damage. It does not capture recovery potential in real time. She reopened the field report. Improper immobilization, secondary collar application, possible torsion. The pieces aligned. She stepped away from the bed and stood beside the monitor. Spinal shock, early window, perfusion dependent. They were mistaking absence of immediate response for permanence. Her pulse slowed. This was not confrontation yet. This was preparation. She reviewed the numbers once more. Blood pressure marginal but adequate, sedation minimal, micromotor present, incomplete cord involvement possible. The detail no one checked was not on the image. It was in the timeline, in the mechanism, in the body itself. She closed the field report and clipped it back in place. Transfer would move him upstairs. Decisions would harden. She had one narrow window before protocol solidified into irreversible momentum. She kept her head down and began planning. The transfer order was already printing when Lena stepped forward. The trauma bay had thinned. Residents gathered tablets. A transport nurse waited near the foot of the bed. The general stood slightly to the side now, speaking quietly into a secure phone. Dr. Kessler reviewed the CT images one last time. "Move him," he said. "Neuro ICU. Prep for surgical consult at first light." Lena felt the window narrowing. If he left this room with the word permanent attached, it would calcify upstairs. She stepped closer, but not into the center. "Doctor," she said, voice low and controlled, "may I clarify the reassessment timeline?" Kessler did not look at her at first. "What timeline?" "For full neurological confirmation," she replied, "given the mechanism and sedation window." Now he looked at her, sharp, impatient. "We've assessed," he said. "Yes, sir," she answered evenly. "However, spinal shock can suppress reflexes early. We're still within the initial perfusion window." A resident glanced between them. Kessler's expression hardened. "Are you suggesting I misread imaging?" "No, sir." Her voice did not rise. "I'm suggesting the clinical picture may evolve." The room felt smaller. The storm outside pressed harder against the glass. Kessler removed his gloves slowly. "You are assigned to monitoring," he said. "Stay in your lane." The words were not shouted. They did not need to be. They carried hierarchy. Several staff members looked away. The general, still near the doorway, heard the tone. Not the content, but the tone. His eyes lifted briefly toward Lena. She did not look at him. She nodded once. "Yes, doctor." Outward compliance, inward calculation. She stepped back to the monitor. The confrontation lasted less than 30 seconds, but it changed the air. Kessler turned back to the residents. "We are not delaying for theoretical recovery," he said. "Proceed." The message was clear. Authority had spoken. Lena returned to the bedside, her face neutral, her breathing steady. She adjusted the blood pressure cuff again and reopened the chart. If she could not challenge verbally, she would fortify documentation. Objective findings only. No emotion, no accusation. She typed carefully. Respiratory variability noted inconsistent with complete cord transection. Sedation timeline within early shock window. Micromotor tone observed in lower extremities under light contact. She avoided interpretive language, just data. The resident who had dismissed her earlier glanced at the screen. "You're over-documenting," he muttered. "I'm documenting," she replied softly. The transport team prepared to move the bed. Lena stepped around to the opposite side. "Doctor," she said again, quieter this time, "may we schedule repeat imaging after perfusion stabilization, even a delayed window?" Kessler exhaled sharply. "There is no clinical indication for repeat imaging at this stage." "Perfusion pressure has improved slightly," she said, "and that does not reverse cord signal change." His voice remained calm, but the dismissal was firm. She nodded once more. "Yes, sir." The general's gaze lingered on her for half a second. He did not intervene. He did not speak. But he had heard enough to register friction. Lena shifted her focus back to the patient. She checked the lower limb again under the sheet, as if smoothing fabric. There, the faint tension remained. She leaned close enough to assess diaphragmatic movement again, still irregular, still inconsistent with full transection. She documented the updated blood pressure reading. Perfusion was slowly stabilizing. That mattered. If spinal shock was masking function, improved perfusion could reveal it, but only if they allowed time. The bed began rolling toward the corridor. Lena walked alongside, maintaining her assigned position. Monitor, IV line, vitals, no more verbal challenge. Not here, not now. In the elevator vestibule, she stepped aside as transport prepared to move upstairs. She requested access to the imaging schedule on the portable tablet. Without commentary, she entered a formal request for delayed repeat imaging in 2 hours, justified by documented perfusion change and evolving clinical findings. It would require attending approval. She submitted it anyway. The system logged the request. Transparent, traceable. Kessler glanced at his tablet seconds later. His jaw tightened. He tapped the screen once. Request denied. The word flashed briefly before disappearing. She did not react. She had expected it. The elevator doors opened. The general stepped in beside the stretcher. Lena remained outside. The doors closed. The reflection in the brushed steel showed her standing still, hands clasped lightly in front of her. Rejected, dismissed, publicly corrected, but the data remained in the chart. Time remained on the clock, and perfusion continued to climb. She turned back toward the trauma bay. The storm had not ended. Neither had the case. The first confrontation had failed, but it had marked the line, and she would not cross it recklessly. She would wait and prepare for the moment when evidence could no longer be ignored. Neuro ICU was quieter than the trauma bay. Quieter did not mean calmer. The general's son lay centered beneath the white lights, cervical collar still secured, lines stabilized, monitors steady but fragile. The declaration of permanence had followed him upstairs like a diagnosis stamped in ink. Dr. Kessler had stepped out briefly to speak with radiology. Residents hovered near the glass partition. Lena stood at the bedside, reviewing numbers. Blood pressure had improved marginally, not dramatically, but enough. Perfusion pressure is not static. It rises and falls with small adjustments. In combat, they learn to guard it like oxygen. She checked the clock. Time since arrival, just over 1 hour, still within early spinal shock territory. She reviewed the chart again. Sedation light, no paralytics, mean arterial pressure borderline but responsive to fluids. This was the window. Small, temporary, but real. She did not announce anything. She simply recalculated. In Afghanistan, under rotor wash and dust, she had once stabilized a ranger pinned beneath debris with suspected cervical trauma. No imaging, no specialist, just anatomy and perfusion logic. When the cord is stunned but not severed, blood flow determines survival of neurons. Subtle repositioning can shift perfusion gradients, not dramatic, not risky if done correctly, but precise. She did not think of it as combat now. She thought of it as physiology. The resident near the doorway sighed as she adjusted the IV line. "Just monitor," he muttered. "Yes," she replied. She reviewed the positioning of the bed. Head slightly elevated, cervical collar secure. But the shoulder alignment created minor tension along the thoracic plane. Not catastrophic, just enough to influence venous return. She looked toward the charge nurse. "May I adjust the bed angle slightly?" she asked calmly. "Pressure management." The nurse shrugged. "As long as you don't compromise alignment." "I won't." No one objected. It sounded routine. She moved to the side of the bed and placed one hand beneath the scapular region, careful not to disturb the collar. With the other, she adjusted the bed elevation by degrees. Not enough to be obvious, just enough to reduce gravitational strain. Then she supported the pelvis gently, ensuring neutral alignment through the lumbar region. Her movements were slow, measured, controlled. She monitored the blood pressure waveform. No spike, no drop, stable. She shifted one more variable, slight reduction in external pressure at the lower abdomen by adjusting blanket tension and abdominal strap placement. Micro adjustments. In the field, they had called it perfusion guarding. Here, it was simply positioning. The resident watched briefly, unimpressed. "Comfort care?" he asked lightly. "Pressure balance," she replied. He rolled his eyes. "Rookie caution." She did not respond. Her focus remained on the monitor. Mean arterial pressure climbed by 2 points, small but real. She waited. 30 seconds. 40. She placed her fingers gently along the lateral aspect of the patient's foot again. No force, just contact. There, a clearer tightening, not dramatic, but stronger than before. She did not change her expression. The monitor displayed a subtle improvement in perfusion waveform consistency. She adjusted one final variable, ensuring the head remained perfectly midline without lateral rotation. Alignment influences flow, always. She stepped back half an inch and observed. The resident glanced at the monitor. "Huh," he murmured. The blood pressure had stabilized at a slightly higher baseline, still within safe range, but trending upward. Dr. Kessler re-entered the room. "What's happening?" he asked sharply. "Perfusion stabilizing," Lena answered evenly. Kessler looked at the screen. "Expected with fluids." "Yes, sir." She did not claim cause. She did not claim credit. She simply returned her fingers to the sheet edge and brushed lightly against the toes once more. This time, the second and third toes flexed, barely, but bilaterally. The resident stiffened. "Did you see that?" he whispered. "Reflex," Kessler said quickly. "Possibly," Lena replied softly. She repeated the positioning maneuver in exact sequence. Micro-adjustment, pause, observe, again. The bilateral movement returned, not artifact, not random, patterned, small, but undeniable. The monitor reflected no instability, no compromise, just incremental improvement. Kessler stepped closer to the bed. "Repeat," he ordered. Lena did. Same precision, same restraint. Again, the flicker. The room grew quiet. No one spoke the word permanent now. She removed her hands and stepped back into her assigned position. Monitor, chart, observe. She did not mention combat, did not reference prior training. This was not about origin. It was about timing and blood flow. The general stood near the doorway again. He had seen the movement. His posture shifted, not visibly to most, but enough. Hope is dangerous in rooms like this. It must be earned carefully. Lena adjusted the IV drip rate slightly within safe parameters to maintain perfusion support. Controlled, measured. She documented the change. Perfusion stabilization maneuver performed under protocol positioning guidelines. Bilateral micromotor response observed. No dramatic language, just data. The storm outside softened slightly against the ICU windows. Inside, the room felt different. Not triumphant, not resolved, but no longer sealed. The combat technique had not been declared. It had simply been applied quietly, and the chord had answered. The first movement was small enough to deny. A single toe, right foot, second digit. It tightened and released beneath the sheet like a muscle remembering something it had lost. The resident leaned forward. "Reflex artifact," he said immediately. "Spinal reflex arc doesn't indicate function." Dr. Kessler did not contradict him. He watched the monitor instead, jaw tight. Lena did not argue. She did not nod either. She simply reset the alignment. Micro-adjustment of scapular support, neutral pelvis, head perfectly midline. She waited until the blood pressure waveform stabilized again. Timing mattered. Perfusion must be consistent before testing. She placed her fingers along the lateral border of the left foot this time. Gentle. No painful stimulus, no nail pressure, just contact. Pause. The room held its breath without realizing it. There, left third toe flexed, then released. Not random, not violent, controlled. The resident shifted uncomfortably. "Still reflex," he insisted, but his voice lacked certainty now. Lena repeated the positioning maneuver with exact symmetry. No extra force, no visible effort. She adjusted the bed angle by 1 degree, released slight pressure beneath the lumbar region, ensured abdominal tension was reduced. Waited. 30 seconds. 40. She brushed the sheet again. Both feet responded. Simultaneous, subtle bilateral microflexion. Not dramatic, but mirrored. The monitor reflected stable perfusion throughout. No hemodynamic instability, no artifact interference. The waveform remained clean. Dr. Kessler stepped closer. His eyes moved from the toes to the monitor, then to Lena's hands. "What did you do?" he asked. Positioning for perfusion, she answered calmly. That does not restore function. No, sir, she replied. It supports it. The resident looked at the toes again. They're responding bilaterally, he admitted quietly. Dr. Kessler's posture shifted, less certain, more guarded. Spinal shock can produce unpredictable activity, he said. Yes, Lena agreed evenly, which is why reassessment is indicated. The word reassessment landed carefully in the room. The general stepped closer to the bedside. He did not speak. He simply observed. His son's toes moved again. Tiny, but purposeful. Lena did not increase pressure, did not escalate. She repeated the maneuver a third time to confirm pattern consistency. Each time, stabilize perfusion. Pause, gentle contact, bilateral response. Pattern confirmed. Dr. Kessler exhaled slowly. Document it, he said to the resident. The tone had changed, less declarative, more cautious. The room felt different now, not hopeful, not triumphant, just unsettled. Certainty had cracked. Lena stepped back half a step to give space. She did not claim the moment. She let the data occupy it. Recommend repeat neuroassessment, she said quietly. Dr. Kessler did not answer immediately. He moved to the bedside himself and applied a controlled stimulus to the plantar surface. More formal, more visible. The toes flexed again. Bilateral, small but undeniable. He tested the opposite foot. Same response. Silence followed. The resident swallowed. That's not artifact, he said softly. Kessler did not look at him. He stared at the monitor as if it might contradict what he had just seen. It did not. Blood pressure steady, perfusion stable, respiration irregular, but present. The general's hand tightened briefly on the bedrail. He remained composed, military composure. But something had shifted in his stance. He was no longer bracing for permanence. He was watching for possibility. Dr. Kessler straightened. We need a full, repeat neurological exam, he said at last. No apology, no admission, just correction. Lena inclined her head slightly. Yes, doctor. The resident began preparing the formal assessment tools, light stimulus, structured response evaluation. Kessler turned toward Lena briefly. You are not to perform further maneuvers without attending oversight, he said. Yes, sir. She accepted the boundary. She did not need to push further. The evidence was already in the room. The perfusion stabilization had opened the window. Now protocol would have to acknowledge it. The general's gaze moved to Lena for a moment. Not praise, not gratitude, recognition. She met his eyes only briefly, then returned her focus to the monitor. The repeat assessment began, measured, structured. When the stimulus was applied again, bilateral response was clearer. Still weak, still incomplete, but present. The declaration of permanence no longer fit the body in the bed. The room had changed, not loudly, not dramatically, but definitively. Lena stepped back into her assigned position, hands still, voice low, watching the numbers, watching the breath, watching the chord answer. She had not raised her voice. She had not defied authority. She had simply waited for the physiology to speak. And now it had. The improvement did not last. Not immediately. 5 minutes into the repeat neurological assessment, the monitor tone changed. Subtle at first, then sharper. Systolic began to drift downward. Mean arterial pressure dropped by 4 points, then 6. The resident glanced at the screen. Pressure's trending down. Dr. Kessler looked up from the chart. Fluid bolus, he ordered. The nurse at the pump adjusted the rate, but Lena's eyes were already calculating. Spinal perfusion depends on pressure. Even small drops can silence recovering neurons. The toes that had flexed moments earlier lay still again. Not because they were gone, because the window was narrowing. Perfusion's falling, Lena said quietly. We're addressing it, the resident replied. Kessler turned toward the monitor. This is exactly why we don't delay, he said. Edema can worsen. Surgical decompression may be required. The surgical plan began forming again in his voice. Permanent injury language resurfaced. The earlier shift in the room began to harden back towards certainty. Lena stepped closer to the bedside. She checked the IV line. Patent, no infiltration. She reviewed the infusion rate. Correct. She glanced at the ventilatory pattern. Still guarded, still present. This drop was perfusion instability, not neurological collapse. The general stood silent at the edge of the room, watching the numbers fall. Lena looked at the clock. If they rushed to surgery under the assumption of complete damage, they would bypass the stabilization window that had just proven incomplete involvement. "Doctor," she said, voice steady, "recommend temporary delay for perfusion stabilization." Kessler turned sharply. "We are not delaying definitive care because of marginal fluctuations." "These fluctuations determine cord survival," she replied evenly. The room stilled. A hospital administrator, who had entered quietly after hearing of the VIP case, stepped forward. "Nurse Ward," he said carefully, "you've already pushed beyond your role tonight." His tone was not hostile. It was warning. "This is a high-visibility case." "I understand," Lena said. "Then stay within protocol." Protocol. The word pressed against her ribs. In combat, protocol sometimes meant following the manual until someone died. She kept her voice calm. "Protocol includes maintaining spinal perfusion pressure prior to surgical intervention," she said. Kessler's eyes narrowed. "You are not in command of this case." "No, sir." "Then do not dictate surgical timing." The monitor beeped again. Mean arterial pressure dipped another point. The resident adjusted fluids, still unstable. Lena's mind ran through options. If perfusion stabilized, micromotor response could strengthen further. If it dropped too long, neurons could fail permanently. She took one slow breath. "Request 5 minutes," she said quietly, "to stabilize perfusion before proceeding." Silence. 5 minutes in a hospital can feel like rebellion. The administrator looked at Kessler. "This is not the time for experimental delays," he murmured. Kessler hesitated. The general stepped one pace closer. He did not speak, but his presence altered the weight of the room. Lena understood what she was risking. Probationary nurse, new transfer, challenging timing on a 4-star general's son. Termination would be immediate and justified under policy. She accepted it. "I will document responsibility," she said calmly, "if stabilization fails." The administrator's expression hardened. "You're prepared to put that in writing?" "Yes." No tremor in her voice. The storm outside rattled the ICU windows again. Kessler looked at the monitor. Pressure dipped once more, then steadied slightly. 5 minutes, he said at last. Not a second longer. The administrator stepped back, displeased, but silent. Lena moved with quiet precision. She adjusted bed angle by fractional degrees, neutral midline, reduced abdominal tension again, supported thoracic alignment. She increased fluid rate within safe boundaries, no dramatic bolus, controlled support. She monitored waveform quality, waited, 30 seconds. The blood pressure stabilized, another 30. It rose by 2 points, then 3. Mean arterial pressure climbed back into protective range. She brushed the lateral aspect of the right foot again. Pause, a stronger flexion, small, but clearer. The resident inhaled sharply. It's stronger, she repeated on the left. Bilateral response again, more defined. Kessler stepped closer. The surgical urgency in his posture softened. He applied formal stimulus again. The toes flexed with visible consistency. Pressure is holding, the resident said. The monitor reflected it. Stable, perfusion restored. The administrator said nothing. The general's jaw tightened once. Hope returning is dangerous. But this time, it was measurable. Lena stepped back to her monitoring position. She did not look at anyone. She documented perfusion instability corrected prior to surgical progression. Motor response strengthened following stabilization. No triumph, no commentary, just record. Kessler exhaled slowly. Surgical plan on hold, he said quietly. The complication had not ended the window. It had nearly closed it. Lena remained still beside the bed, career uncertain, authority strained. But the cord was answering, and for now, that was enough. The repeat imaging was not ordered loudly. It was requested quietly after the second confirmed bilateral motor response. Dr. Kessler stood beside the CT console in radiology, arms folded, eyes fixed on the new scans as they rendered layer by layer. The ICU was held in suspension during the wait. No one said permanent anymore. No one said recovered either. They said nothing. Lena stood at the back of the control room, hands clasped lightly in front of her. She had not followed the stretcher closely. She had no need to. The data would speak now. The images appeared. Sagittal first, then axial. Kessler leaned closer. The initial scan had shown diffuse cord signal change at C6. Severe, bright. Now, with perfusion stabilized and edema slightly redistributed, the margins were clearer. Signal change was present, but not complete. There was preserved cord continuity along the posterior column, subtle but intact. Kessler did not speak for several seconds. The radiologist cleared his throat softly. "There is incomplete involvement," he said. "Signal suggests severe contusion with edema, not full transection." The room exhaled without meaning to. Incomplete. The word replaced permanent like a quiet correction written in pencil over ink. Kessler straightened slowly. He studied the images again, as if searching for the mistake. It was not there. The mistake had been temporal, too early, too certain. The general stood beside him now. He had not asked to be brought in. He simply appeared when imaging began. "Explain," he said calmly. Kessler adjusted his tone. "The cord is severely injured but not completely severed. There is preserved continuity." "Recovery potential?" the general asked. "Possible," Kessler replied carefully. "Significant rehabilitation required. Outcome uncertain, but not permanent paralysis as initially feared." The general nodded once. He absorbed the correction without visible emotion. Then he asked a single question. "Who noticed?" The room stilled. It was not accusatory, it was direct. Kessler's jaw tightened slightly. The radiologist looked at his console. The resident beside Lena glanced at her, then back at the general. No one answered immediately. Hierarchy hesitated. Silence in hospitals can feel heavier than noise. Lena kept her eyes on the floor. This was not her moment. She had no desire for it to be. She had done what physiology required. Recognition was irrelevant. The resident swallowed. "She raised concern," he said finally. His voice was steady but quiet. "She questioned the timeline, documented the micromotor responses, requested reassessment." Kessler did not interrupt. The general's eyes moved across the room until they settled on Lena. She did not lift her gaze immediately. When she did, it was brief, controlled. The look he gave her was not gratitude, not relief. It was assessment, recognition of discipline, of restraint, of someone who spoke when necessary and remained silent when timing required it. "You are?" he asked. "Lena Ward," she replied. "ER float nurse." He nodded once. "You were certain?" "No, sir," she answered evenly. "I was cautious." The distinction mattered. He studied her for another moment. "You acted despite resistance," he said. "I documented objective findings," she replied. "No embellishment, no defense, just record." Kessler shifted slightly. "I made an early declaration based on available imaging," he said. "The admission was controlled, but present. The reassessment window altered the picture." The general turned his gaze back to the screen. "Timing matters," he said quietly. "Yes, sir," Lena answered. The room felt different now. Authority had shifted, but not violently. It had rebalanced. Kessler did not lose his position. He simply adjusted it. The surgical plan was modified. Conservative management prioritized. Perfusion guarding protocol reinforced. The machine of hierarchy recalibrated around new data. The resident looked at Lena once more. His earlier dismissiveness had dissolved. He gave the smallest nod. Acknowledgement. No apology spoken. The general stepped away from the console. As he passed Lena, he paused briefly. "Thank you," he said. 2 words. Level. Controlled. Not public praise. Not theatrical. Just professional recognition. She inclined her head slightly. "Yes, sir." He continued down the corridor toward ICU. Lena remained where she was for a moment longer. The images still glowed on the screen. Incomplete involvement, preserved continuity, possibility. She closed her eyes briefly, not in relief, in recalibration. The case was not over. Recovery would be long, uncertain, but permanent had been replaced with potential. The shift in authority was subtle, not in rank, not in volume, but in where the room looked when answers were needed. And for one measured moment, it had looked at her. She returned to the ICU without comment. There were vitals to check, perfusion to maintain, and a window still open, quietly. The ICU lights had dimmed slightly to simulate night, but no one in the room felt the difference. Reassessment began formally this time, structured, documented, observed by more than one set of eyes. Dr. Kessler stood at the foot of the bed. The resident positioned himself at the side. A second attending from Neuro ICU entered quietly, arms folded, watching without comment. Lena remained at her assigned position, monitor, lines, perfusion. No one asked her to lead. No one needed to. Light plantar stimulus, Kessler said. The resident applied controlled pressure to the right foot. There was a pause, then movement, clearer than before. Toes flexed with visible coordination, not just tension. "Left," Kessler ordered. The same response followed. Not strong, not decisive, but deliberate. The resident swallowed. "Repeat," Kessler said. They did. Consistent bilateral motor response. Kessler shifted slightly. "Voluntary?" the second attending asked. "Possibly emerging," Kessler replied. He moved to test proximal muscle engagement, subtle quadriceps activation. There was faint contraction, barely perceptible, but present. Lena adjusted the IV flow to maintain steady perfusion. Mean arterial pressure held stable. Respiratory variability remained controlled. She did not watch the toes. She watched the numbers. Motor response improves when perfusion holds. It declines when it doesn't. The body was answering carefully. The room was listening now. After several repetitions, Kessler stepped back. "Document return of bilateral motor activity," he said quietly. The resident typed without looking up. No one spoke the earlier word. Permanent had vanished from the room. In its place, severe cervical contusion with incomplete cord involvement. The second attending nodded. "Diagnosis amended," he said. "Prognosis guarded but not fixed." Guarded, not fixed. The language shifted from certainty to caution. Dr. Kessler avoided Lena's gaze when he stepped toward the chart, not in shame, in recalibration. His authority had not collapsed. It had adjusted under evidence. The hospital administrator appeared at the doorway again, face tight. He listened to the amended diagnosis. His eyes moved quickly, calculating implications, media, liability, reputation. He stepped closer to Kessler. "We will need to review the communication timeline," he murmured. Kessler nodded once. "Later." The administrator glanced toward Lena briefly. Recognition there too. She had complicated their narrative, but in doing so, preserved the case. The general entered quietly as reassessment concluded. His son lay still, but no longer silent beneath the surface. The general listened to the amended report without interruption. Incomplete injury, Kessler said carefully. Recovery possible with aggressive rehabilitation. How possible? The general asked. Uncertain, but measurable motor return is present. The general nodded once. He turned toward Lena. Remain assigned to this case, he said. It was not a request. It was calm instruction. Lena met his gaze briefly. With respect, sir, she replied. I was just doing checks. The resident glanced at her. She kept her tone neutral. I'll continue monitoring until shift change. The general studied her. Just doing checks, he repeated softly. Yes, sir. He stepped closer to the bed rail. You mentioned perfusion stabilization earlier, he said quietly. The word perfusion carried weight, not common in casual speech. You've used that term before. She did not answer immediately. She adjusted the pulse oximeter, ensuring waveform accuracy. In trauma cases, she said evenly, maintaining cord perfusion pressure can preserve function. He watched her for a moment longer. Where did you learn that phrasing? In training, she answered. He did not press, but recognition flickered. Not rank recognition, not uniform recognition, pattern recognition. The way she stood, the way she spoke only when necessary, the way she measured time in seconds, not sentiment. He nodded once. Continue your checks. Yes, sir. He stepped back to his son's bedside. The resident approached Lena quietly after. You were right, he said under his breath. She shook her head slightly. It wasn't about being right. He hesitated. Still. She returned her focus to the monitor. Mean arterial pressure stable. Motor response reproducible. Respiratory variability present but manageable. No one applauded. No one announced a reversal. The amendment would be written into the chart. Corrected, clinical, controlled. Dr. Kessler completed the updated documentation without looking up. The administrator stepped into the hallway to make a call. Damage control had begun. Lena remained beside the bed. Hands steady, voice low. Shift not yet over. The cord had not healed. The battle was not won. But the diagnosis had changed. And sometimes that is enough. The general's gaze rested on her once more before returning to his son. He had recognized something, not her history, not her past, but her discipline, and he would not forget it. Lena adjusted the IV line again and kept watching the numbers. Dawn reached the ICU slowly, not with color, with soft gray light filtering through reinforced glass, dulling the harsh fluorescent glare that had ruled the night. The storm had passed. Rain clung to the windows in thin, quiet streaks. Inside, the monitors still hummed, but the tone had changed. The general's son lay propped slightly higher now, cervical collar secure, lines stable. The swelling had not vanished. The injury remained severe, but something was different. Try again, the neuro-attending said softly. The patient's eyes flickered open briefly, not fully conscious, but aware enough to follow instruction. Move your right toes. There was a pause, then measurable movement. Not reflex, not artifact. A deliberate attempt, small but unmistakable. The resident exhaled slowly. Documented voluntary response, he said. The attending nodded. Left. A weaker movement followed. Still voluntary, still present. The general stood at the bedside, hands resting lightly on the rail. His face remained composed. Years of command had trained his expression to contain reaction, but his shoulders lowered slightly. That was enough. Lena stood at her usual position near the monitor. She adjusted the IV rate to maintain stable perfusion. She did not step forward. She did not speak. Her work was in the numbers, blood pressure holding, oxygen saturation steady, perfusion pressure within protective range. The cord had answered again. By 6:45 a.m., the amended diagnosis had been finalized in the chart. Severe cervical contusion with incomplete cord involvement. Voluntary motor response present. Prognosis guarded, functional recovery possible. Permanent no longer appeared anywhere. No announcement was made to media, no hallway filled with reporters. Security remained quiet. The hospital communications team drafted a statement about a serious but stable condition without further detail. No mention of a nurse, no mention of timing. The administrator approached Lena near the nurses' station just before shift change. "Ward," he said carefully. She looked up from her charting. "Yes, sir. We would like to discuss your role last night." She nodded once. He lowered his voice. "There is a vacancy opening in Neuro ICU, permanent placement, pay adjustment." She studied him calmly. "Why?" she asked. He hesitated. "Your clinical judgment." She considered the offer, then shook her head slightly. "I'm comfortable floating." He looked surprised. "At least consider advancement." "I would prefer something else," she said. "What?" "Protocol review," she replied. "Guidelines about premature paralysis declarations, clear reassessment windows documented before communicating permanence." He blinked. "That's administrative." "Yes, sir." "You'd trade promotion for policy adjustment?" "Yes." He studied her for a moment. "Submit it in writing." "I will." He nodded and stepped away. No applause, no formal commendation, just paperwork shifting direction. The general approached quietly as Lena completed her final chart entries. He did not bring security with him this time. He stood beside her without urgency. "My son moved his foot," he said calmly. "Yes, sir." "You were measured," he continued, "not dramatic." She kept her gaze on the monitor. "Physiology required time." He nodded once. "In my field," he said quietly, "we call that discipline." She did not answer. He looked at her for a moment longer. "I will not make this public," he said, "but it will not be forgotten." She inclined her head. "That's not necessary." "It is," he replied evenly. He extended his hand, not ceremonially, professionally. She shook it once, firm, controlled, no audience. He released it. "Continue your work," he said. "Yes, sir." He stepped back to his son's bedside as Lena gathered her things. Shift complete. She walked down the corridor toward the general ICU bays. In Bay 4, an elderly patient stirred restlessly. No security detail, no rank, just a man recovering from pneumonia. Lena stepped inside, adjusted his IV line, and smoothed the blanket at his shoulder. "Morning," she said softly. He nodded faintly. The monitor beeped in steady rhythm. Outside, the first full light of day washed over the hospital facade. Inside, the hierarchy reset. The night's tension dissolved into routine. No headline carried her name. No promotion letter waited in her locker. Just a note in the protocol system awaiting review. She checked the elderly patient's oxygen flow one more time, adjusted the drip by a fraction, steady, unnoticed. The general's son slept in ICU, cord intact enough to fight. The diagnosis corrected, the window honored. Lena moved to the next bed. Calm, measured, head down. The hospital resumed its rhythm, and she returned to the quiet work that saved lives without spectacle.